First of all, thank you very much for inviting me over here. My, my sincere thanks for GICES team for inviting us over here. In interest of time, when we talk on this subject, we will be talking about what can be done in this increasing MDR resistance scenario and a small study that we did to try to understand whether we can have some alternatives in dealing with MDR infections. And one of them was, can we revive some aminoglycosides which have action against our common pathogens so that we can take the pressure off from our workhorse antibiotic which is failing, the carbapenems. So isopamycin is an aminoglycoside antibacterial with properties which are very similar to a routine aminoglycoside, just like amikacin, but has better activity in account of resistance against the aminoglycoside neutralizing enzymes, which are 1,6-acetyl transferase, has a good spectrum against gram-negative bacteria, and certain staph also effective against a couple of CRE bacteria, is pretty nephrosafe, and it is very much stable against aminoglycoside neutralizing enzymes, can be given intravenously or intramuscularly in a dose of 8 to 15 milligram per kg per day. One of the main reasons for looking at this was when we searched the literature, this drug has fared very well among all the aminoglycosides for its stability, avoidance of any kind of inoculum effect, as well as purely bactericidal and synergistic in its action, and has shown very well responses in our preliminary evaluations. So Dr. Neeraj Tyagi and myself, we were kind of forces behind conceptualizing a pilot study where our three co-investigators, Dr. Ami Varaya from Nanavati Max Super Speciality Hospital, our microbiologist, Dr. Bansidhar Tarai from Max Super Speciality Hospital, New Delhi, and Dr. B.N. Chaudhary from Peerless Hospital, Calcutta, we defined a kind of proof of concept study to understand whether we can use this drug in most of those community-acquired or hospital-acquired infections where we can take the pressure of carbapenems. So it was a prospective, observational, and comparative study of in vitro susceptibility of isopamycin against clinical isolates from various clinical sources, and this is called as a triple I study or isopamycin in India. This was an in vitro susceptibility of isomycin against all these clinical isolates. It was an observational study. 50 patients from each center were taken. Males or females of 18 years above, both inpatient and outpatient clinical isolates from urinary sample, as well as intra-abdominal, endotracheal, bronchoalveolar lavage samples and steroid blood samples were taken. And all other samples collected from patients apart from those mentioned in the inclusion criteria were the exclusion criteria. Methodology, the samples were collected from various sources and delivered to laboratory. They were streaked on McConkey agar high media, sheep chocolate agar bioMérieux, and sheep blood agar bioMérieux using a calibrated loop. They were incubated and observed for bacterial growth. Identification of the bacterial species was done using Vitek 2 compact fully automated system, and they were interpreted as per the UCAS guidelines. The E-test was used to quantify the MICs. The CLSI breakpoints were used for interpretation of susceptibility to all antimicrobial agents except for isopamycin. For isopamycin, the breakpoints were proposed in 2010 CASFM, which was a Society of Microbiology from France, and the susceptibility was defined by an MIC less than 8 and resistance was defined as an MIC more than 16. The percentage of bacterial isolates were categorized as susceptible, intermediate or resistant based upon these UCAS guidelines. When we look at the various sources from the three centers, the respiratory, urine, intra-abdominal and blood samples, a total of 150 samples were taken. Majority of them were respiratory samples, 30% of them were urinary samples, and 15 and 13% were respectively intra-abdominal and blood samples. This was the breakup, majority of them respiratory and followed by urinary and intra-abdominal blood samples. The summary of sensitivity and its distributions were defined as susceptible or resistant, and finally statistical analysis was done to understand what could be the implications of this drug. There was a reasonably 1:3 female to male ratio. There were total 50 samples from females and 100 samples from male. The age range was from 18 to 96 on center 1, 20 to 87 and 23 to 86, but mean age would be around 63 in all these centers. The isolated samples were basically, majority of them were Klebsiella, Pseudomonas, Acinetobacter, and E. coli. So these top 4 samples actually constitute for the more than 85% of the samples. Of them, Klebsiella was the predominant one, and they all were coming practically in a similar fashion from most of the centers. This was the breakup, with Klebsiella contributing nearly 27%, Pseudomonas 25, Acinetobacter 22, and E. coli 20. So these 4 major representative isolates were what we were focusing on, whether we can have an alternative antibiotic for these, and can we revive one of our aminoglycosides which have been long lost. So these were the susceptible pattern. When we looked at that across all the centers, 93% of the E. coli isolates were susceptible to isopamycin. 57% of Pseudomonas were susceptible, and barely 55% of Klebsiella. Others were not really as significant to talk about because their numbers were very less. In general, nearly 59 to 60% sensitivity for all those tested isolates were observed. 90% of E. coli, again, in the urinary isolates were sensitive, and we had a separate subgroup analysis, how many of them were carbapenem resistant. A lot of them were carbapenem resistant. I don't have the exact numbers, but nearly 50-55% were carbapenem resistant as well. The Klebsiella, again 69%. Pseudomonas and Acinetobacter didn't show any kind of a good response, and we had very few samples in the urinary isolates of Acinetobacter or Pseudomonas, so conclusion cannot be well drawn. Another, blood isolates for all bacteremias, the 3 samples, E. coli were 100% sensitive. Staph, enterococcal, though they were very small numbers, total 13 samples, they were showing reasonable sensitivity, but Klebsiella and Acinetobacter didn't have great sensitivity patterns. In intra-abdominal sample, again, E. coli and Pseudomonas did show a very good response, and Klebsiella and Acinetobacter again bordered on a 60-33%, overall 74% sensitivity for intra-abdominal samples. In respiratory samples, whatever Pseudomonas were grown, they had a 53% sensitivity. Serratia, only 1 sample. Acinetobacter and E. coli had actually shown only 3 samples from respiratory sample were E. coli, but they all were sensitive. So in respiratory samples, a dismal 41% sensitivity for this was shown. The comparative analysis, when we looked at the MICs, very, very ultra-sensitive MIC less than 1, this was very heartening to see that E. coli retained a very sensitive pattern. Nearly 77% of E. coli isolates had an MIC less than 1. Though the MIC less than 8 would be called sensitive, anything more than 16 was resistant. And majority of the Klebsiella also showed a very good sensitivity pattern. Pseudomonas was mixed, and overall, I would say majority of E. coli samples had high sensitivity to isopamycin. Comparison with gentamicin was done for the same samples, and this showed that we had nearly 46% of those isolates were sensitive to gentamicin, which was just another proof of concept that we can use preferentially this aminoglycoside in this highly increasing resistant potential isolates. When we compared with amikacin, even there the sensitivity was very, very poor, and this was one of the proof that we wanted to establish. Comparative sensitivity at a glance, isopamycin MIC less than 1 was found in 77% as compared to 47 and 7% for gentamicin and amikacin respectively. These were the graphical representation from various areas where again isopamycin did show a significant sensitivity pattern in all across. In urinary samples specifically, isopamycin had extremely good MICs, less than 1, as compared to gentamicin and amikacin. And we can reasonably well draw the inference that highest susceptibility of isopamycin recorded in III study was against E. coli in all the samples. Average susceptibility of isopamycin recorded in this Indian study was against E. coli, followed by Pseudomonas and Klebsiella. Isopamycin would be a good choice in urinary tract infections caused by E. coli. The average susceptibility of isopamycin recorded in the study against all these isolates was 59%. And we once more want to kind of emphasize that for E. coli urinary tract infections, we have a good option of using isopamycin in our scenario. And it has a reasonably good sensitivity against MDR, Klebsiella, and Pseudomonas to be added in a combination to provide a good synergistic action. And this would probably kind of make us think again about complicated urinary tract infections. Thank you very much.